CNS infarction is another example of liquefactive necrosis. Like we mentioned yesterday, that anytime we have infarction to any part of our organ or tissue, we normally get coagulative necrosis. But the only exception is in the brain, right? So in the brain, infarction will lead to liquefactive necrosis. So let's look at the histology. Features or histology changes that we're going to see with CNS infarction, just the same thing that we did for myocardial infarction. So with CNS infarction, we definitely know that there will be decreased oxygen delivery to the tissue, right? And because of that, the tissue, which is going to shift to anaerobic metabolism, and there will be increased lactic acid. And this lactic acid, right, can decrease the pH inside the cells, and at the same time, it can also denature the protein, right? And what we're going to see as a result of that, right, in the first 12 to 24 hours, if somebody have CNS infarction, right, because of the decreased pH inside the cell, those cells, they have to have more affinity for eosinophil. So when you apply your eosinophil, you're going to see eosinophilic cytoplasm with eosinophil. And then we start seeing the breakdown of the breakdown of the nucleus. And this together is what we normally refer to as red neuron. So when you use them using the word red neuron, that's what they refer to as red neuron. So red neuron is usually seen at the early stage of CNS infarction. At the early stage of CNS infarction within 12 to 24 hours. And by 24 to 72 hours, then we also have the neuroglial cells. They will start to release hydrolytic enzymes, and then this hydrolytic enzyme will start to liquefy the tissue. And of course, we can also have neutrophil infiltration. So the neutrophil can start to move into the tissue, and they can also release hydrolytic enzymes, like we mentioned earlier. And the effect of all these hydrolytic enzymes, right, they want to hydrolyze the tissue, and that will lead to liquefactive necrosis. And then by day 3 to 5, right, then we start seeing microglia start to move in, right? And the microglia is the macrophage of the brain. So when we see them using the word microglia, basically what it means is the macrophage of the brain. I would know that macrophage is what normally like do the upkeeping, right? Taking care of any garbage in the brain, right? Or in this in our body. So those macrophage now is going to remove all these debris, this liquefactive necrosis, try to remove them. And that removal is going to create like a space in the brain, like a cystic space in the brain, right? And by 1 week to 2 weeks, right? So now we need to fill back this space or try to repair it. And what normally helps with repair in the brain is going to be your astrocyte, right? So astrocyte normally help with repair, right? So this astrocyte is going to start to proliferate. So the astrocyte is going to proliferate, right? And then try to repair this space, this cystic area, right? And that proliferation of the astrocytes is what we call reactive gliosis. So whenever there is injury to the CNS, one of the things that we normally see in the injury is reactive gliosis because they're trying to repair this. Just like a patient with multiple sclerosis, whenever they have those autoimmune attack to those oligodendrocytes in the brain, right? The reactive gliosis, the astrocytes want to proliferate in response to those injury, and we're going to see those reactive gliosis, right? And of course, you can also see vascular proliferation. And in more than 2 weeks, right? You're going to see those glare scar. So you're going to see those scar tissue. So what will be the complication of this, right? So if somebody keep having so the complications, so like at this point, right, during the phase of this liquefactive necrosis, when the tissue is very soft, right, if during this time, right, this patient, they are very high risk, right, especially when the necrosis is going on, they are very high risk for hemorrhagic conversion. Because there are different types of stroke, which we want to talk about later, ischemic stroke, hemorrhagic stroke, right? So those patients, they are high risk for hemorrhagic conversion. So that's why if somebody is having ischemic stroke, we normally tend to hold off on anticoagulation. We don't want to put them on therapeutic anticoagulation because of this risk of hemorrhagic conversion, right? During when the brain is very soft, right? And the other complication that we should also be aware of, right? If somebody is having recurrent stroke, right? Which I normally call chronic brain ischemia, right? So these people, they have to be losing a lot of brain tissue, right? Because each time somebody has a stroke, they're losing brain tissue, and this can lead to brain failure. Just like what we have for heart failure, right? So this patient can have brain failure. And a brain failure, right, is what we normally call, we call it dementia. So this can lead to dementia, right? And of course, if dementia is secondary to stroke, we call it this fancy word, vascular dementia. And I hope we've learned something today. Don't forget to subscribe to this channel. In the next conversation, I'm going to be talking about fat necrosis, fibrinoid necrosis. I'm going to cover the rest of the necrosis. Thank you guys for watching.